Thank you, Xavier. It's a pleasure to share with you this session. Good evening, everybody. I try to give you some, I don't know if I will reach to give you the answer, but probably it's a debate for a future discussion. This is my conflict of interest with no relation with the talk. So the background is, in introduction, the World Health Organization and the US CDC and the OMS have recommended the use of higher FiO2 and mainly around 80% in all adult surgical patients undergoing general anesthesia to prevent mainly the surgical site infection. This is the main major recommendation. This recommendation has arisen several discussions. As a matter of fact, there are numerous studies with different results about the effect of FiO2 on surgical site infection. Some positive study, I will show the major one coming from Boston from the group of Professor Sessler, some neutral study and some negative study. This is why really a debate about the impact of the FiO2, and I will try during this 50 minutes maybe to give you some direction to change the paradigm that we have today, and maybe we have some change between the paradigm in ICU patients and in OR patients. So, moreover, what I said, the clinical effect of FiO2 or the potential harmful effect of FiO2 are not limited to infection control, and we will see that we have also different side effect of higher FiO2 on other organs. So this is just a joke with my colleague, just the presentation before, less than 1 hour, our colleague friend Julien Potécher with Mavin Singer, leading by Marc Léon, the session before management of sepsis in ICU. And I don't know if the scientific committee asked the same question to Julien than asked to us. One is for critical care patient and one is for anesthesia patient, surgical anesthesia patient. And Julien nicely presented the side effect of hyperoxemia and also of hypoxia. I will try to combine both. So why worry about oxygenation and or PO2 or SpO2 targets? First of all, as you know, probably high level of oxygen is toxic. However, it's given in million people in the world. As you know, the oxygen is the most drug prescribed in the world in the hospitals. Second, higher FiO2 induced lung injury in animal models and potential lung injury in humans, both in healthy and ALS patients. On this slide, you have at the left a normal lung, as you see, and this is a model of mice exposed to higher FiO2 above 95% during 3 days. And as you see, you have a total hemorrhagic congestion with mild intra-alveolar deposition. It looks like damaged alveolar, as we can see in human ALS patient. This is a sample model as just to expose a higher FiO2 patient, and especially when you have the same data coming from the babies, from the premature. So more oxygen you deliver, more radical oxygen spices you have. Then more ROS, more cell injury, as you know. However, lower oxygen also induces more risk of hypoxemia. Then more hypoxemia also induces more tissue hypoxemia, and then you have more cell injury. So you have every variable, like every physiological variable, you have a U-shape. A lot of it's no good, and the lower value is also no good. So you should try to have an optimal value for each one. So you know the ROS production induces direct side effect on the lipid membranes degradation with the lipolysis, and the proteolysis also DNA degradation, and indirect side effect such as inflammation, mediator production, phagocytose activation, and other that we speak about. So why the story never end about the controversies of in OR, should we use higher FiO2 or lower FiO2? The two largest SCT performed before 2 2010 that evaluates the use of higher FiO2 in a surgical patient. The first one published in New England Journal 20 years ago, coming from the group of Professor Sessler from Boston, and the second one from the group of Meha from the JAMA, yield conflicting results. These two studies are probably the two landmark studies calling in question of the potential value of FiO2. So my concern is maybe in the real life, especially in France, maybe we could discuss after for North America, most surgical patients received an FiO2 between 40 and 60%, resulting in saturation for the majority of the patient above 95 or 96%. This is a real life, and that's we can ask us why we discuss about very low or very high FiO2, and in the real life, the majority of anesthesiologists set their FiO2 around 50%. So my slide that I perform now is all the studies have been performed in the period when the conventional non-protective ventilation were applied, mainly for the studio. And I checked all the study. None of them used PEEP or high level of PEEP. All of them used no PEEP, ZIP means, or PEEP around 2 or 3 centimeters, and probably all of them, as I saw, use high tidal volume, means around 10 milliliters per kilogram. This is before 2005. And now we are in a new area which is called the lung protective ventilation, with at least a low tidal volume, less than 10, maybe around 7 milliliters per kilogram of predicted body weight, associated to a positive and expiratory pressure, at least around 5 centimeters or above. This is the talk of Emmanuel, and I think now my point of view is probably maybe it's time now to change the paradigm for this a single value of FiO2 during all the surgery, and probably we could now change the paradigm around an individualization of the FiO2 delivered on our oxygen saturation target. This is maybe, I think, in the future, like exactly the same that arterial tension or everything that we said just before. This is just to remember you the main results of the Professor Sessler first trial, and the study was stopped prematurely by after 500 inclusion. And as you see, the primary endpoint was the surgical site infection, and the other reported that a high FiO2 at 80% decreased by half the infection from 11 to 5%. This was the first positive one. We can discuss some limitation, but was probably one of the best performed study at this period. One study just after, there are a lot of study about this topic, but the two major on this one is the proxy study. The proxy study published less than 10 years later showed that negative results, neutral results, the most important study, this is against FiO2 80%, did not find any differences in the site infection or atelectasis or lung infection and respiratory failure, and also death. This was absolutely a nice study, even it's not a randomized controlled trial, it's a trial. So according more than around 20 randomized trial, the different societies made all of them recommendation to use higher FiO2 during surgery, mainly during abdominal surgery, in aim to decrease the surgical site infection. This is another one of the CDC, including more than 5,000 studies to try to decrease the site infection for all surgery. And you see, the oxygenation is also recommended to use higher FiO2. So this is another one I like, because this is clearly and honestly said is a strong recommendation with moderate quality of evidence, as said. And in fact, when we summarize the majority of them, some of them recommended to have a target of oxygen saturation instead to have a fixed level of FiO2, and all of them are agreed today to have at least equal or to above 90% of oxygen saturation. And then after, we have several narrative review and systematic meta-analysis with different methodology. This is one of them, and showed that the positive result in favor to the higher FiO2, and we have other one, as you see here, which negative study according some additional more recent study. And this is exactly what we said with the different meta-analysis according the type. And in this study, no TSR were performed. So this is another trial more recently, and the other used a composite score and find no difference using high FiO2. So this is one of the last recent study. We have several study of meta-analysis showing different results. So really, we could not conclude. And about the atelectasis, as you know, probably Professor Emmanuel Futier will speak about this. All the studies performed in anesthesia initially were performed without PEEP, and then all was probably correct, but according without PEEP. If you applied PEEP, we have totally different results, and the higher FiO2 did not induce atelectasis in presence of positive and expiratory pressure. This is really a major issue to change this concept, especially for the pre-oxygenation. It's not the issue about this, but take care of this. This is one more for me. The more reasonable is probably to, as said, this recommendation is to avoid high oxygen FiO2 during anesthesia and surgical procedure in most patients, because FiO2 between 0.3 and 0.4 sometimes is totally enough in the real life. So my message is, what about ICU patient for the same question? Does FiO2 impair outcome in critical care patient, and what we could learn from ICU data to transfer in OR about oxygen tag and FiO2? I just before finish summarize for me two very nice study on two concepts. This is the one major coming from the ANZI group of New Zealand and Australia, mainly leading by Ronaldo Bellomo, is the ICU ROCKS study, including 1,000 patients, and compared two levels of oxygenation according to, as you see here, one conservative oxygen therapy and one usual oxygen therapy. This is according, you see, the target of oxygen saturation with a safety range also. So the results are neutral, no significant difference in the mortality, which was the primary endpoint. As you see, you have around 20% in both groups with the conservative or liberal oxygen strategy. Now the others planned and started the MEGA-ROCK study. What is the MEGA-ROCK study? I like this. Is the largest study will perform in ICU patient, and it will include more than 40,000 patients in ICU, all the patients in the world who will receive the oxygen therapy, both non-intubated and intubated patients. It's really impressive design study that I want to present you this study. And I think we can do probably the same as we discuss sometimes with Xavier in OR. And this is the last study that I want to focus on. It is a French one coming from the group of Gilles Capelier from Besançon, and the others compared in RDS patient, in severe RDS patient, that a strategy according to conservative oxygenation with a SpO2 of ranging from 88 to 20 to 92% in comparison to the usual care, which is called liberal oxygenation, to set the FiO2 and PEEP to obtain an oxygen saturation above or equal to 96%. And as you see here, the study was stopped early. I know this study well because I was in the safety board, and we decided to stop the study in the second interim analysis due to 5 DC related to mesenteric ischemia in the conservative oxygen group. And this is very important to also, my message, to have a safety target. In conclusion, first of all, as we know, most surgical patients received in the real life an FiO2 between 40 to 60%, resulting for the majority of them in values of oxygen saturation above or equal to 90%. So, in my point of view, no final conclusion can be done using a single FiO2 for all the patients during the perioperative period and for all the type of surgery. Probably it's not the same. Cardiac surgery, thoracic surgery, abdominal surgery should be separate. And then maybe for the future, and a safety SpO2 target than a fixed FiO2, which called personalized or individualized FiO2, like that we performed the FLASH study in France, according to the arterial tension. And then today, evidence does not support in the routine to use an FiO2 higher of 60% during anesthesia and surgery, especially in the patient with healthy lung, while the risk of adverse events, including mortality, could even be increased with some high FiO2. In conclusion, my message is we need now new randomized control trial in the area of protective ventilation, as it will be presented by Emmanuel in the next presentation. Thank you very much for your
Thanks, Amir. Thanks a lot for this very interesting topic and very interesting lecture centered on the FiO2 in the patient. One of the questions on the chat is very interesting because the colleague said, you speak about FiO2, you speak about ventilation, so you adapt the ventilation, you have now a personalized ventilation, but we don't have a personalized FiO2, right? The following during the surgery of the oxygen, it's mainly the saturation, right? We mainly follow the patient on the saturation. And we don't have any idea about the consumption, the cell consumption of oxygen by the patient. So the question is, do we have to change and to do a study on personalized saturation of oxygen in the patient, as we did for the ventilation, more than change the FiO2 of the patient to be at high FiO2 or low FiO2. So centering on the saturation, right or not right?
This is a good question in the real life. However, as I tried to present it, oxygen is depending of the FiO2 setting, but also the PEEP setting. That means you have two parameters to set to have an FiO2. As you know, the table of RDS, for example, you have to obtain the same level of oxygen saturation by two different combinations. One high FiO2 and low PEEP, and another one is high PEEP with low FiO2. This is probably available in RDS patient with lung injury, but maybe the concept could be translated in healthy lung patients, because we know that oxygenation is just a surrogate. It's not what happened in the alveoli, because we can have a good oxygen saturation, but we can have some injury in the lung due to high FiO2 or due to baro or to volotrauma. This one is not only a single parameter to set with FiO2 for the future. This is my point of view. And the second point, you're absolutely right. What will be the best surrogate of what happened in the cell? Oxygen saturation is just a macro surrogate of what happened, but we don't know exactly what happened in the microcirculation for this. This could be the future using other monitoring for the future.
Yeah, I think it's interesting to associate the the oxygen transport and the hemodynamics, right? Because you can have a higher FiO2 if you have a very low mean pressure, for instance. The transport of the oxygen is, as a consequence, quite bad, and you will have some consequences of these FiO2. So, okay, it's a situation.
In the trial that performed by the group of Danny Sessler, the first New England Journal, but Professor Sessler is here. They measured in 50 patients, I think, the oxygen tension to evaluate the oxygen delivery in the skin and why is the mechanism of decrease of the surgical site infection. Is it correct, Professor Sessler?
Yes, supplemental oxygen does increase tissue oxygen. And tissue oxygen is necessary for oxidative killing by neutrophils. So there were many reasons for believing that supplemental oxygen would reduce the risk of surgical wound infection. And as you presented, that's what we initially found. And in a 500-patient study, there was actually a 300-patient study that followed that. Since then, we've done many other studies, as have other groups, and pretty much consistently there has been no benefit. And the most recent was the 5,700 patient controlled trial from Kurtz and colleagues that we did at the clinic, showing no benefit whatsoever. In a meta-analysis of reliable studies, there appears to be no benefit. The field was a little complicated because there were about 5 flat-out fraudulent papers contributed by a surgeon, and it's now clear that they were fraudulent. If you take those out, nobody sees a benefit anymore. So 20 years ago, when things were different, prophylactic antibiotics were used differently, patients were allowed to get hypothermic, maybe oxygen mattered, but it's clear that it no longer does for surgical site infection. But it's also clear that intraoperatively, it's harmless. It does not cause atelectasis up to 80%. When you get to 100%, it takes one breath to cause atelectasis. But 80% appears to be safe.
Okay. Thank you, Dan.